Today we are going to discuss the topics of what diabetes do to our kidney and what hypertension does to our kidney and what other diseases do and what other havoc and do other chronic diseases play in our kidney. Do you know that when a disease becomes chronic, a long standing, it starts throwing a protein called amyloid. Amyloid is a beta pleated sheet. These are proteins, these are beta pleated sheets that we do not have enzymes to digest these sheets. And when they accumulate in certain parts of the body, they just hamper or damage the body, and they prevent the normal body function. The same happens in the kidney. When they are thrown in the kidney, they damage the kidney. In diabetes, since the whole body is affected, so is the kidney. Do you know when a diabetic, if you have a patient of diabetes in your home, you must be knowing that when there is a follow up for a diabetic patient, there is renal function test, and then they're doing some cardiac test like ECG, and for kidney they're doing renal functions, and there is ophthalmoscopy and examination of the retina almost every year. And that is because all these three places have end arteries. When the end artery of an organ gets affected, that organ goes to a place of no recovery. Because if there is a damage in the retina doesn't come back. If there is damage in the heart, what happens is myocardial infarction, depending on the area that undergoes infarction or the area that undergoes death, depends that gives fate of the patient, that decides the fate of the patient. What I mean to say is there can be sudden death, and some people can have several myocardial infarctions and still survive. So it is the area, small area or large area, and the area like if SA node area gets affected, posterior artery of the heart gets affected, then there is sudden death. But what happens in the kidney? There are two prime causes of death in these patients, diabetic patients. The first, uh, the first cause of death is myocardial infarction, and the second is cause of death is the renal failure. And why heart is foremost is that when an end artery damages occur, or when the artery of the heart is damaged, the area of the heart dies and is not replaced. But in the kidney, we have two kidneys and we have 50% reserve. Like we have been discussing what happens when one kidney is donated. Only 50% of the nephrons are there in the, if one kidney goes away, then only 50% of the nephrons are left in the kidney. And if 50% of the nephrons are left, they're good enough to function. But if there is any further loss, it compromises the function. Any further loss compromises the function. Same goes for diabetic nephropathy. It keeps killing the nephrons till 50% of them are left. And if 50% are left, any further damage results in compromising the function till there is end stage renal disease. So you know from your previous knowledge that there is microvessel damage in diabetes and there is macrovessel damage in diabetes, right? What are microvessels and what are macrovessels? Microvessels are something, the vessel size is, um, you can say arterioles, and the capillaries are microarterioles. The arterioles and capillaries are microarterioles. Arterioles are supplied by sympathetic stimulation and they are regulated by a host of other factors that include hormonal and other chemical factors, oxygen, etc. So we will work on both the lesions, microvascular and macrovascular. Both of them together damage the kidney. The kidney lesions have specific names, and we now we know very well that kidney is a high pressure area, because the this is the only place where capillaries have two arteries at their end. They don't have a vein at their end. Afferent and efferent arteriole are two arteries. So there is no vein there, right? So it's a high pressure area. Three lesions are encountered. Where are those three lesions encountered? One is glomerulus, other is renal vascular lesion. You can say the artery and the arterioles get affected, right? And then there is pyelonephritis, including necrotizing papillitis. So the pyelonephritis is infection in the interstitium, and that involves the tubules and later creates much of the necrosis there and smudge there. So in, let us study each lesion separately. I wish to have some more time with you guys so we can revise all this glomerulonephritis stuff, because uh, these glomerulonephritis really confuse with each other, and we can do some scenarios so we have some fixed ideas which lesions are, or how will you diagnose or separate each lesion from the other? How will you diagnose each lesion, or how will you segregate these lesions? So this is the normal portion of the kidney, and this is the abnormal portion of the kidney. And abnormal portion of the kidney is showing leaky glomerulus that has thrown all the albumin in the uh, urinary space. This albumin is irritant and will cause a lot of damage. You know that when we talk of arteriosclerosis in the rest of the body, or atherosclerosis in the rest of the body, we talk of atheromas. And what are atheromas? Accumulation of lipid in subendothelial layer of the vessel. In case of the renal diseases of the kidney, or in case of the glomerular lesion or the vascular lesion of the kidney, there is more of hyaline deposition because of this protein leakage than the lipid deposition. So it is different in the kidney than the rest of the body. Most important glomerular lesions are capillary basement membrane thickening. So capillary basement membrane thickening is not accompanied by any antigen antibody complex deposition there. Diffuse mesangial sclerosis is there. So mesangium or the mesangial cells increase, and so does the mesangium matrix increase, and all of that causes sclerosis. Nodular glomerulosclerosis. The glomerulus takes form of nodules, right? And that is nodular glomerulosclerosis. It has a special name, and that is Kymelston-Wilson lesion. Capillary basement membrane thickening is there. So this is the capillary, and the basement membrane is around here. Diffuse mesangial sclerosis is there. The mesangium increases and causes sclerosis. Nodular glomerular sclerosis, later on it develops forms of nodules. So widening and thickening of capillary GBM, glomerular basement membrane, occur in all cases of diabetic nephropathy. Not it is not in particular person. In everybody there is GBM thickening, and that is because of the microangiopathy. Microangiopathy is arteriolar and capillary lesion. Pure GBM thickening is detected by electron microscopy, which means electron microscope only shows increased thickness of the GBM, and there is simultaneous thickening of tubular basement membrane as well. The thickening continues progressively in along the mesangial, along with mesangial widening. continuously and progressively thickening increases and keeps increasing. And what will that happen? Look at this distal convoluted and proximal convoluted tubule. They have really thick basement membranes, and this thickening keeps increasing. And this is the same goes in the Bowman's in the glomerulus. The same goes for the tubules. Morphometric studies show that thickening of GBM begins 2 years after the onset of type 1 diabetes mellitus. So, type 1 diabetes mellitus is since birth, and just 2 years of age, this starts happening. GBM starts thickening. By 5 years, there is 30% increase in the size of the GBM. There is diffuse increase in mesangial matrix, right? In early disease is mild proliferation of mesangial cells that is not prominent in this, that is not prominent in injury, but later the mesangial cells increase, and they're associated with thickening of the GBM as well. And this is shown by periodic acid shift stain. Periodic acid shift stain detects glycoproteins. As the disease progresses, mesangial area expansion extends to nodular configuration. That is the third lesion we have to encounter. So, the progressive expansion of mesangium correlates with deterioration of renal function, as such as increasing proteinuria. Because there will be, if there is increase in all these structures, you can think of ischemia of the vessels as the endpoint. If there is increase in GBM, progressive increase in mesangium, and everything keeps increasing, they will eventually cause proteinuria and deteriorating renal function. So this is the GBM that will increase in size. The GBM of microtubules increase as well, and this GBM will further cause deterioration in renal function. It will be porous. There will be leaky membrane. Though GBM has increased in size, but it will be leaky, causing initially selective proteinuria. So, nodular glomerular sclerosis is called as Camel-Steele-Wilson lesion. And if in case any scenario, MCQ, whatever, talks about Camel-Steele-Wilson disease or lesion, then don't think a lot. It is just diabetes, a change of nodular glomerular sclerosis in diabetes. Intracapillary glomerular sclerosis, it is also known as Camel-Steele-Wilson lesion, and the glomerular lesion takes the form of ovoid or spherical laminated nodules of matrix situated in the periphery of the glomerulus. Glomerular lesion take the form of nodules now. You can see this nodule in the matrix of mesangium, that is Camel-Steele-Wilson nodule. This is the normal mesangium, this is the abnormal mesangium. If mesangium of single focus uh, goes abnormal in the kidney, it will definitely affect the normal area as well. See, the normal kidney is normal and there's nothing wrong with it. But for an abnormal kidney, when one area gets affected, it will have some effect on the normal area. These nodules are PS positive and they lie within the mesangial core. Nodules are surrounded by parietal epithelial capillary loops or loops that are markedly dilated. So, if nodules are formed in the mesangium and they're throwing out albumin in the urinary space, what gets affected here? The parietal layer of the Bowman's capsule. What gets affected here is the parietal layer of the Bowman's capsule. And what havoc can the parietal layer of Bowman's capsule play? It will proliferate, and if it proliferates, what is that called as? Crescent. And if there is crescent formation, what can that do? rapidly progressive renal failure, right? Rapidly progressive renal failure. That is what it can do. Nodules are surrounded by patent peripheral capillary loops or loops that are markedly dilated. So these capillary loops can be normal looking, or those could be dilated, because when this capillary loop is compressed, then it will transfer its function, or because it will not be capable of functioning, the sick loop will not be capable of functioning normally. So the normal portion will take up the load, and it may get dilated, or you can say that it may look normal initially and later get dilated, depending upon how many capillary loops are compressed. The nodules show features of mesangiolysis, another huge havoc. Nodules show mesangiolysis. Where do this show mesangiolysis? String of the mesangial capillary lumen interface. Mesangial capillary lumen interface gets affected. Disruption of the site at which the capillaries are anchored to the mesangial stalk. Untethered capillaries distend outward due to force imparted by the intracapillary blood pressure and flow. This produces capillary microaneurysms. Let us understand by the diagram. The capillary loops got affected, mesangium proliferation occurred, right? And that caused dilatation in some of the loops. Then he's talking about mesangiolysis. The capillary endothelium, this is the mesangial area, the capillary, this is the mesangial area. So the mesangiolysis occurs at the interface between capillary loop and the mesangium. And when there is mesangiolysis here, during the process, it rips off the basement membrane as well. If it rips off the basement membrane, then that will cause a lot of leaky membrane. Disruption sites at which the capillaries are anchored to the mesangial stalks. And then what else happens is that there is disruption in the areas where capillary stalks are attached. Here, the capillary stalks are attached here. So there is disruption in this mesangial area as well. And what will that do? Untethered capillary distend outward to the force imparted by the intracapillary blood pressure flow. What will happen now is that the capillary loop, since the area between mesangium and capillary stalk has been disrupted, so the capillaries having high pressure will force their way down here, right? These capillaries will force their way down here. And then what will happen? This produces capillary microaneurysms, right? So increased mesangiolysis occurs at mesangial and capillary loop lumen interface, and there is disruption of mesangial stalks as well. And this disruption will distend the untethered capillaries outwards because of the force imparted, and this will create microaneurysms. Nodular glomerular sclerosis. Uninvolved lobules and glomeruli show diffuse mesangial sclerosis. As the disease advances, individual nodules enlarge, compress, and engulf capillaries, obliterate the glomerular tuft. So, as the individual nodules large, they will compress on the capillaries, and they will cause narrowing of the capillaries, therefore, and engulf the capillaries, obliterating the capillary loop. Look at the nodule. These are the nodules. One nodule, another. Those are the nodular lesions. You can see a lot of hyaline deposition in the nodules. Hyaline deposition that has raised from the surface will now compress on the capillaries. Look at the compressed capillaries. These are compressed capillaries. So if it compresses on these capillaries, it will decrease the flow of blood there. And decreased blood flow means oliguria, right? It engulfs the capillaries, obliterating the glomerular tuft. I think that gives a better understanding that pressure on these capillaries because of the nodular lesions will obliterate them, and it will decrease the urine flow as well. The accumulation of hyaline material in capillary loops is called as fibrin caps. These are fibrin caps and or capsular drops. Hyaline material adherent to the Bowman's capsule is capsular drops. Is there any hyaline material adherent to the Bowman's capsule? Yes, there is lot of there. Hyaline cap, green arrow. See, there the hyaline material is attached to the Bowman's capsule, right? So this is the uh, hyaline cap. And red area, the Kymelston-Wilson lesion. Kymelston-Wilson lesion, Kymelston-Wilson nodules here, right? So those red arrows are there. And then you can see you see in addition atrophic tubules with basement membrane thickened. Atrophic tubules with a thick basement membrane are here. These are atrophic tubules, and the basement membrane of these atrophic tubules are thick. And this is what is the blue arrows show, because the tubules will undergo atrophy as well. So the whole nephron is getting affected. Almost in every area there is pathology in case of diabetes mellitus. Therefore, renal function is very important to do. Both afferent and efferent arteries show hyalinosis. They're not showing atherosclerosis, they are showing hyalinosis. So as a result, glomerular and arteriolar lesion of the kidney suffer from ischemia, tubular atrophy, interstitial fibrosis. If there is atrophy, fibrosis sets in and undergoes overall contraction. The kidney undergoes contraction in size. About 15 to 30% of long-term diabetics develop nodular glomerular sclerosis and eventually renal failure. 30 to 15 to 30% of the long-term diabetics. I think in Pakistan this figure is far higher than what is shown here, because I've seen too many diabetics undergoing dialysis, and that is very much true that after myocardial infarction, kidney gets affected very badly, and the cause of death is renal failure. And all right, renal arteriosclerosis and atherosclerosis, macrovessel disease in diabetics. That is vessels larger than the arterioles. So what happens to them? One of the most frequently severely affected organ is the kidney. Changes occur in arteries and arterioles are similar to those found in the other tissues, which mean a lot of fat deposition is there. This is the glomerulus getting its nodular configuration. And for the rest of the thing, it says it is just like that of the adult kidney. But we are more concerned about what goes on in kidney alone in localized lesions. So these are all Kymelston-Wilson lesions. Glomerular sclerosis is there, and lot of hyaline material is deposited to cause nodular formation. These are multiple nodules. Multiple nodules are there, hyaline nodules. This is Kymelston-Wilson lesion. Highline arteriosclerosis affects afferent and efferent arterioles as well, because they are arterioles. Such efferent arteriole is found only in diabetics. This is a lot of protein deposition, leaky protein here. First, there was protein deposition inside the mesangium, and that caused Kymelston-Wilson lesion. And when there was mesangiolysis, the mesangiolysis caused it caused protrusion of the capillaries into this into the space, the central tethering space, this space. this one, and lot of proteins are lost. These long strands show fibrin deposition. Whenever you see long thread-like strands, they are fibrin deposition. In acute or chronic inflammation of the kidney, that usually begins in interstitial tissue and then spreads to affect the tubules. Both acute and chronic forms are more common in diabetic. Diabetics tend to have more severe involvement. Pyelonephritis. Pyelonephritis, how does it begin? Inflammation in the kidney begins in the interstitial tissue. It doesn't begin in the tubules, it begins in the interstitial tissue and then it spreads to the tubules. It can be acute or chronic, and whatever it is, whether acute or chronic, since the these diabetics are immunologically compromised, the cells don't work as efficiently, and nor do the immunoglobulins are as effective. So they have more severe form of acute or chronic pyelonephritis. In acute form, what happens is necrotizing papillitis, necrosis occurs, right? This is what is necrotizing papilla. The whole papilla has undergone necrosis. There is a lot of inflammatory cells there, and there are cells that are dying. Inflammatory cells and the cells that are dying. Papillary necrosis. So it is not only the diabetes that will cause papillary necrosis, there are other conditions that will cause the same. And mnemonic is SODA, sickle cell, obstructive pyelonephritis, diabetes, and analgesics. All of them cause pyelonephritis. These are just the pictures at the end of the topic of diabetic uh, uh, diabetic kidney. So it is not only one problem in the kidney, it is necrotizing papillitis, it is Wilson's disease, glomerulopathies, multiple sort of glomerulopathies come in, and then in the arteriolopathies come in, arteriolar diseases come in. So it is better to describe each and every lesion separately, so it is easier to discuss. And please, dear students, don't try to read diabetic changes from your chapter in the kidney. These are mentioned, all of these are mentioned in endocrine chapter. The kidney changes are mentioned under the heading of diabetes in the kidney chapter. They're not in the diabetes chapter. The only thing the book says is you can refer to the next chapter. When it says like that, you don't skip, you just read the next chapter. You don't say, okay, never mind. You have to read the next chapter or whatever place it says. Nephrosclerosis, these are hypertension changes in the kidney. So we do know several people, or it's a very common disease, hypertension, raised blood pressure, and these affect in kidneys in a very special manner as well. This is a term used for renal pathology. It is associated with sclerosis of renal arterioles, small arteries, and hypertension, which are both cause and consequence of nephrosclerosis. If there is any decrease in the renal blood flow, we know that juxtaglomerular apparatus is in the in the kidney, and that detects low blood circulation, increases hormones in the body to increase blood flow, and therefore increase the blood pressure, right? Increase blood flow to rise the blood circulation, and a normal uh, per- perforation of you can say the normal blood supply to the organs. Affects vessels. Vessels undergo thickening, thick walls, consequently narrowed lumen. The result is focal parenchymal ischemia. Ischemia leads to glomerular sclerosis, and chronic tubulointerstitial injury occurs. This produces reduction in functional renal mass. So you get my point. Because of nephrosclerosis, when what is blood pressure? It is the lateral pressure exerted by the blood on the lumen of the vessels. So that is what is blood pressure. So in case of nephrosclerosis, when there is thinning of the arteries, no matter whether it is because of the leakage of the vessel wall, because of selective or non-selective proteinuria, whatever damage is there. So if it is because of that, that will still cause narrow lumen and result in focal parenchymal ischemia. That is also dangerous because it is still capable of throwing hormones in the blood. Ischemia leads to glomerular sclerosis. There is sclerosis of the glomerulus. Chronic tubulointerstitial injury occurs, and that reduces functional renal mass. It is associated with advanced age, frequently affects the plaques, and may be seen in the absence of hypertension, right? Diabetes and hypertension increase the incidence and severity of the lesion. So, if the hypertension occurs as an independent event in a person who is not actually suffering from hypertension, there is lesser damage. But if a person has diabetes along with hypertension, it's a bigger problem because both of them cause individual lesions, and these individual lesions eventually become combined to cause a mega lesion. Pathogenesis: two processes participate in arterial lesion: medial and intimal thickening as a response to hemodynamic changes, aging, genetic defects, and some combination of these. So, medial and intimal thickening. Why does that occur? Three big problems: genetic defects, aging, and hemodynamic changes. Hyalinization of arterial wall. Why is it caused? Extravasation of plasma proteins and increased deposition of uh, Bowman's matrix. The kidneys are either normal or they become reduced in size. A hypertensive kidney becomes smaller in size. The average weight of kidney is somewhere between 110 and 130 grams, and then it becomes small in size. It weighs less. The cortical surfaces are fine, even granularity that resembles green leather. The loss of mass is mainly due to the cortical scarring or shrinking. Now, just let us put some mind into that. High blood pressure is there. High blood pressure is exerting more lateral force on the vessels. More lateral force on the vessels will damage some arterioles more than the rest, and damage arterioles with neighboring normal arterioles will cause areas of normal and abnormal kidney surface that gives rise to grains on the kidney, right? That gives rise to grains on the kidney, and that is called as, that resembles leather grains. And these grains are because of the scarring that is occurring in this fashion. Even granularity is there, and loss of mass because of scarring of the tissue. This area, the lower pole, has even changed in color from mahogany brown to just brown. The gross picture of granular surface corresponds to microscopic subcapsular scars of sclerotic glomeruli and tubular cells that drop out, right? So alternating with a better and preserved parenchyma. So just look at here. This shows a better granularity of the kidney. So that has alternating normal and abnormal surface. If you do a biopsy here, you will find sclerotic glomeruli and tubular dropouts. There is narrowing of the lumen of arterioles and small arteries causes thickening and hyalinization of the walls. Highline arteriosclerosis is there. Highline arteriosclerosis is there, causing eventual thickening because of hypertension. The interlobular and arcuate arteries show medial hypertrophy, replication of internal elastic lamina, myofibroblastic tissue in the intima, all of which narrow the lumen. If you put your mind into that, every cell in all the layers is proliferating. So we're talking about cells in individual layer as in the media there is medial hypertrophy and replication of internal elastic lamina is there, and there is increased myofibroblastic tissue in the intima, right? And every change narrows the lumen. This is called as fibroelastic hyperplasia since elastic tissue and fibrous tissue along with the muscular hyperplasia is there. So this is called as fibroelastic hyperplasia. And not only that, highline arteriosclerosis is there as well. So highline deposition is there that will cause narrowing of the arteries calling, and that is called as highline arteriosclerosis. It increases in severity with age, and there is presence of in the presence of hypertension. So in uh, all age people, that is what happens in all age people. Actually, what happens in age is slightly different than what happens in primary hypertension cases or essential hypertension intention cases. What happens in age is hardening of the arteries because of calcium deposits in the vessels and also because of the atheroma deposits in the vessels, and that very badly affects the kidney. And what the kidney does is fibroelastic hyperplasia. What the kidney does is fibroelastic hyperplasia of the vessels, which further narrows the vessel, further increases the blood pressure. This is normal. This is pre-hypertension getting narrowed, but not as narrow as this one, right? In hypertension, in full-blown hypertension, there is much narrowing or sclerosis of the vessel. Morphology consequent to a vascular narrowing, there is patchy ischemic atrophy, right? And that consists of tubular atrophy and interstitial fibrosis. There is tubular atrophy and interstitial fibrosis. A variety of glomerular alterations come into play. And what glomerular alterations will come into play, we will just see in a minute. Renovascular hypertension, this area that has got two blood vessels, uh, two arteries, high vascular area, will respond to high blood pressure very badly. Loss of individual nephrons result in familiar sandpaper kidney. He calls it the granular kidney calls the granular kidney a sandpaper kidney. And before we said that it looks like a leather, and the granular kidney looks like leather. He calls it sandpaper kidney. High blood pressure from any cause eventually becomes self-perpetuating by damaging small arteries of the kidney. And increase in blood pressure has all the reasons to cause further rise in the blood pressure. When ischemic changes are pronounced and affect larger areas of the parenchyma, they can produce wedge-shaped infarcts or regional scars with histological alterations. They produce infarcts, right, or regional infarcts. And all of whether it's a wedge-shaped infarct or renal infarct, we will have some histopathological changes, or we can have some histology to study there. This is a wedge-shaped infarct, right? This is the wedge-shaped infarct, or there will be regional scar there, or region can have a scar. One region can have a scar. Morphology, the later includes collapsing of the GBM, deposition of collagen within Bowman space, periglomerular fibrosis, and total sclerosis of glomeruli. Collapse of the GBM, and collagen is deposited in the Bowman space. If there is collagen in the Bowman space, that will collapse the GBM. And what will happen? Periglomerular fibrosis will eventually take place. And what will happen there? Then there will be total sclerosis of the glomeruli. This is the end stage. This is the end result of all of the above. That glomerular fibrosis will narrow the Bowman space, and also it will collapse the GBM, and it will cause sclerosis of the glomeruli. This is, just look at this. This is a Bowman's capsule. Look at the arteriole inside. Big arteriole and a tiny little lumen. Clinical features: uncomplicated nephrosclerosis does not cause renal efficiency or uremia, but three groups of hypertensive patients with nephrosclerosis are at increased risk of developing renal failure. Who are those? Uncontrolled high blood pressure and underlying secondary disease, for example, diabetes mellitus. So, uncontrolled high blood pressure, uncontrolled hypertension, uncontrolled diabetes mellitus. And African people, there is some genetic problem in their immunological system, or there is some problem with them that they undergo disease condition quite often. Renal efficiency supervenes after prolonged hypertension. Renal insufficiency, yes, definitely the kidney won't work. So it will be called as renal insufficiency. Rapid renal failure will occur as a result of malignant hypertension, the blood pressure that keeps increasing. You know what is malignant hypertension or accelerated phase of hypertension? What is malignant hypertension? When do you diagnose malignant hypertension? Give me systolic and diastolic pressures. Just be quick. Someone type it. Blood pressure in malignant hypertension. No answer. All right. Response: you are failed. Nephrosclerosis. All right. Somebody answered. Thank you very much. No, it's not the right answer. That is not malignant hypertension. That is definition of a high blood pressure. Malignant hypertension has got blood pressure. Malignant nephrosclerosis, or malignant or accelerated hypertension, has got blood pressure of diastolic blood pressure is high. Yes, there is to some extent right. 120. 120 is the diastolic. Systolic goes above 200. 180 is also right, because some places may say 180, but the diastolic is above 120 or anything above 120, and 180, some say 200, some say all right, maybe 180 is taken as baseline for some places. Malignant nephrosclerosis. Rarely it is sudden in onset. Malignant nephrosclerosis, it takes long time to develop. In a normal intensive individual, it may be found there. You can find malignant nephrosclerosis, but it is very rare. Actually, you don't find a malignant nephrosclerosis. You can only find nephrosclerosis. You can only get consequences of, because of consequences of other diseases, you get this one. Commonly, it is superimposed on pre-existing essential hypertension, secondary forms of hypertension, underlying chronic renal diseases, particularly reflex nephropathy, individual with a systemic sclerosis. Young individuals, hypertension, malignant hypertension is uncommon in but it occurs in people, 1 to 5% of the people, and in its pure form, it affects young individuals, men, and in blacks, it is more common. Fundamental lesion is vascular injury. Fundamental lesion is vascular injury. Initial insult is vascular damage to the kidney and might result from a number of cases. For example, if there is long-standing hypertension, arteriolitis, coagulopathy, or they all occur in combination. Long-standing hypertension will cause malignant hypertension, right? Because of the hormones that it throws, renin, angiotensin 2, arteritis, and coagulopathy. Arteritis is caused by damage of the vessels because of high blood pressure. And if there is damage to the blood vessels, what will happen? Coagulation. Ali Ijaz, you can't hear me. Why is that? Please check your system. Initiating event injury endothelium, and that results in initiating event is endothelial injury. And how did endothelial injury occur? Turbulent flow. Increased permeability of vessels to fibrinogen. In case of kidney, there is loss of proteins from there, and these proteins damage in addition to turbulence. So there is small vessel fibrinogen and other plasma proteins that leak. Focal death of vessel wall and platelet deposition. So this can lead to fibrinoid necrosis of arterioles, small arteries, intravascular thrombosis because of activation of platelets and coagulation factor. What can this lead to? Microinfarcts. What can this lead to? Fibrinoid necrosis of arterioles, small arteries, intravascular thrombosis because of activation of platelets and coagulation factor that can cause spread in the whole of diffuse, or you can say focal spread of, there is focal spread of these infarcts, microinfarcts. Look at this. This is blood vessel that is not quite visible, a thrombus is forming, and whole lot of inflammatory cells have gathered here. These will cause interstitial inflammation as well, and interstitial inflammation will cause necrotizing papillitis. So everything goes hand in hand, and the blood vessel is almost non-visible now. And if that happens, what will happen? Hyperplastic arteriosclerosis. Why does it get hyperplasia? Because of mitosis stimulating factors. Mitosis stimulating factors are platelets, platelet-derived growth factor, plasma proteins in other cells. They cause hyperplasia of intimal smooth muscles, right? So what causes hyperplasia are mitogenic factors. Plasma proteins, we have lots of them coming out of the leaky GBM or glomerular apparatus. And then there are platelets, there are platelet factors, platelet-derived growth factor, other cells through their cytokines to cause hyperplasia, resulting in hyperplastic arteriosclerosis, which is very much typical for the malignant hypertension. This causes further narrowing of the lumen and markedly kidneys become ischemic. Severe involvement of renal efferent arterial cause now comes in the hormones. Renin-angiotensin system gets a powerful stimulus. Patients with malignant hypertension have raised plasma renin level. This sets a self-propagating cycle in which renin-angiotensin 2 causes intrarenal vasoconstriction. Renal ischemia perpetuates in renin secretion. So angiotensin 2 and renin, both of them cause vasoconstriction, and more vasoconstriction will result in lesser blood supply and further raise in these hormones. Kidney size now becomes small. because of ischemia. Kidney size varies depends on the duration and severity of hypertensive diseases. Small pinpoint petechial hemorrhages appear on the cortical surface. So kidney has started crying, and it has started crying by showing pinpoint petechial hemorrhages on its surface, and it is weeping with blood due to rupture of arteriolar and glomerular capillaries. We call it flea-bitten appearance. We call it flea-bitten appearance because it looks like that. So the kidney is weeping with small and large hemorrhages in areas where there are just petechial hemorrhages. They look like a flea-bitten area. Two histological alterations that characterize blood vessels in malignant hypertension are fibrinoid necrosis of arterioles and intimal thickening. Fibrinoid necrosis, this is a form of necrosis that occurs when cytological detail of the vessel wall or the cells of the vessel is lost. Vessel wall appears smudgy, eosinophilic due to fibrin deposition. Inflammation is absent or minimal. Sometimes glomeruli become necrotic, infiltrated by neutrophils. Glomerular capillaries may thrombose. Uh, do you see any visible do you see any visible cell there? Do you see any uh, endothelial cell? Do you see any Bowman capsule, visceral epithelial, or parietal epithelial cell? No, you don't see any. Nothing is visible. So cytological detail is lost. There is smudgy eosinophilic appearance because of fibrinoid deposition there, smudgy appearance. Inflammation is minimal or sometimes neutrophils are present. You can see two lobes here. Yes, these are neutrophils. Three lobes here. The nuclei have two lobes or tends to have lobes. So some neutrophils tend to infiltrate. Now there is time of thrombosis. Damaged vessel wall will cause thrombosis. Intimal thickening is because of proliferation of smooth muscle cells, concentric layering of collagen, and accumulation of pale staining proteoglycan and plasma proteins. You can see here healthy Highline arteriole, hyperplastic arteriole, it differs, and then there is necrotic arteriole. Whole of this area has undergone necrosis. Hyperplastic hyperplasia. Just look at this one. Intimal thickening when it is because of hyperplasia. Intimal hyperplastic arteriole is like onion skinning. Do you remember this word? We have studied onion skin elsewhere. We have studied onion skinning in Ewing sarcoma. The the radiograph shows onion skinning. That is the radiographic picture of Ewing sarcoma. Do you remember the same in gallbladder? Do you remember the same in gallbladder? Do you remember studying the stones in the gallbladder? There was onion skinning there. The alteration onion skinning because of its concentric appearance. The lesion is also called as hyperplastic arteriolitis. It corresponds with renal failure. There may be superimposed intraluminal thrombosis. Arterioles and arterial lesions will result in narrowing of vascular lumen, ischemic atrophy, at times infarcts, and that is distal to the abnormal vessels. Clinical features: full-blown syndrome in malignant hypertension is characterized by blood pressure over 200. So my student said 180, but 180 could be the criteria for some hospitals or some places, but in general, it is said that it is 200. Diastolic blood pressure is very dangerous, and it is 120 millimeter of mercury. Papilledema, retinal hemorrhages, and cephalopathy cardiovascular abnormalities, and renal failure. Whenever malignant hypertension is diagnosed, all of these specialists are involved. All of these specialists involved. We call the eye people to examine for the papilledema, or even the medical people. I had a ophthalmoscope and in my pocket I used to examine myself, and this is because this is an emergency situation. You don't rely on others. At times you are in emergency situation. So in our country, unfortunately, our system is not very efficient. So you should know these things by yourself. Look at the blood vessels of the eye and know what they look like. So retinal hemorrhages can be there, which is an emergency. Encephalopathy, patient starts talking nonsense and nuisance, and they talk of, they start hallucinating, and that is encephalopathy. That is how you diagnose clinically. And then there are cardiovascular abnormalities. You understand myocardial infarction very well now. And then the kidney fails. The early symptoms are related to increased intracranial pressure and include headache, nausea, and vomiting. Well, headache, nausea, and vomiting, visual impairment, particularly scotomas, which are blind spots in the eye, right? Scotomas are blind spots in the eye. These are the early features of high blood pressure. And then what happens is loss of consciousness and convulsions. Why is there this encephalopathy? And why should there be encephalopathy? Increase in the toxic material in the body. At the onset, there is marked proteinuria, microscopic or macroscopic hematuria. What is microscopic hematuria? You see it under the microscope. Macroscopic, you can see when the patient urinates, or you can see by your own eye. Renal failure soon ensures. Syndrome is a medical emergency, requires aggressive and prompt antihypertensive therapy to prevent irreversible renal injury. Irreversible renal injury is fibrosis everywhere. When fibrosis sets everywhere. Before the current antihypertensive drug, malignant hypertension has 50%. When we were not treating the malignant hypertension, we had 50%, half the patient died within 3 months of onset. Half of our patient had died within, 50% had died within 3 months of the diagnosis. And in 1 year, there were 90% of the patients had gone, so it means only 10% lived, which is terrible, which is very bad. At present, about 75% of the patients survive 5 years. That is much better. 5 years, 75% for 5 years is much better. 50% survive with a restoration of renal function. That is really good. So stop kidney damage, take care of diabetes, take care of hypertension, and we have to have controlled cases rather than uncontrolled cases. We have Henocholine Purpura, which is a generalized body condition mentioned in a paragraph in your book. Henocholine Purpura is mentioned elsewhere in the book, like in chapter of blood vessels. I'll not go in much detail of this Henocholine Purpura because it is just the same as IgA nephropathy. What was specific for IgA nephropathy? It had mesangial deposits. That was specific. Nothing, no other disease had immunoglobulins deposited in the mesangium. It had immunoglobulin IgA deposited in the mesangium. Second, something very specific for this that IgA nephropathy, which is Berger's disease, was nephritic syndrome, right? So those were two specific features of Berger's disease. IgA nephropathy induced by any causative agent, external causative agent, like there could be respiratory disease first, like sore throat or streptococcal infection, later leading to the to actually this disease. Their manifestation of the same disease. Children 3 to 5 years are affected, more severe. The ages are same, right? Atrophy follows atopy, upper respiratory tract infection. IgA is deposited in the mesangium. Morphology is variable. Mesangial proliferation there, and endocapillary crysenteric glomerulonephritis. Crysenteric glomerulonephritis later leads to rapidly progressive glomerulonephritis. How do you diagnose crysenteric glomerulonephritis? There is proliferation of the parietal epithelial cells. There are mesangial deposits, increase in the mesangial cells and mesangial matrix, diffuse mesangial proliferation is there, crescent formation is there, and rapidly progressive glomerulonephritis sets in. This is what rapidly progressive glomerulonephritis looks like. Skin lesion. Yes, skin lesion we did not study before, but skin lesions are same as before. Subepidermal hemorrhages, necrotizing vasculitis involving small vessels of the dermis. Look at the focal collection of this is inflammatory cells, focal collection of inflammatory cells. These are perivascular collection of inflammatory cells. There are vessels located inside of these inflammatory infiltrate. Purpuric, I think we can just go through the same again because there is not much to read about this disease, and even the rest of the diseases I will just go through quickly. Lupus nephritis and all I will go through quickly because they're systemic diseases of having a minor effect in the kidney or involving the kidney. But when the kidney is involved, it is really one big problem, a very big problem. What are the vital organs? One vital organ is, give me name of three vital organs. Kidney, heart, and lungs, right? It is kidney, heart, and lungs, right? Heart, lung, right? Kidney, heart, lung, and kidney as well, right? So it is kidney, heart, and lungs. So when the kidney have problems, we have big problems. Lung, we do have collateral circulation. We have two vessel supply in the kidney.
अस्सलाम वालेकुम मैम।
All right, khatam ho gaya time.
जी मैम।
Okay, no problem. Okay, bye students. Now we can inshallah start from the same area next time. Okay, Allah Hafiz.